we'll move to the second topic of discussion today. Third line therapy. How do you choose the right TKI at the right time? And these are our two experts, my very dear friend, Dr. Stalin Bala Chowdry, who works at Mahatma Gandhi Institute, another Mahatma Gandhi Institute. We have a lot of them in India, but this one is in down south in Vizag in India. And our international expert is Dr. Kendra Sweet. You've already seen her and heard her. She's from Tampa at the Moffitt Cancer Center. And I'm going to stop share. And Dr. Stalin, you can start sharing your slides and go ahead with your presentation.
Thank you, sir. Thank you for the introduction and a very good evening and good morning. Thank you, SMLA, for this opportunity. So my two cases are on the second topic for the today. So that is the third line therapy. How do you choose the right thing at the right time? So I'm presenting two case scenarios. The first case scenario. So a 30-year-old male without any comorbidities initially evaluated in June 2013. So he has complaining of dragging abdominal pain and fatigue for 2 months. So he had a massive splenomegaly, 20 centimeters below the left costal margin. His hemogram showed an 1.8 lakh of WBC count with left shift and myeloid peak, and CML was pretty confirmed with the cytogenetics and the BCR-ABL, which showed that the major transcript was present, and the so-called ELTS score was high risk. Initially, he was started on hydroxyurea for 2 weeks and later started on Imatinib 400 mg once a day. So it was through the compassionate care program through GPAP. So he attained complete hematological response in 6 weeks. And the toxicities were the facial puffiness, mild rash, and the grade 1 cytopenias. Otherwise, he has tolerated the drug well. And BCR-ABL at 6 months was 0.8%, and at 1 year it was 0.3%, and he attained MMR at 20-month time point. At 3 years, that is 36 months, he attained deep molecular response, and he maintained it till June 2021. So almost 8 years down the lane of use of IMAT. So after that, he had an infrequent follow-up. He lost MMR in June 2019. After that, so he had infrequent follow-up, and he was counseled for strict compliance and advised to come after 8 weeks for the repeat testing. But he was had very infrequent follow-up. So the bone marrow biopsy in November 2021 showed CML-CP with secondary myelofibrosis, and TKD mutation testing was done, which showed that Y253H mutation was detected and BCR-ABL was 29.559%. So patient was started on Dasatinib 140 mg once daily. He had frequent cytopenias, which this is pretty much common in our country. So majority of the patients won't tolerate the Dasatinib at a dose of 140 mg. So at least in my experience, I had seen very frequent cytopenias with the Dasatinib 140 mg once daily, and the dose was reduced to 100 mg. So at 6 months after usage of Dasatinib, the BCR-ABL was 15%. So the dose again was hiked to 140 mg, and the patient didn't tolerate the dose and again reduced to 100 mg. So the repeat BCR-ABL after 2 months was 18%. So again, the TKD mutation testing was repeated and it showed T315 mutation. So he was lost to follow up for 5 months. There was an history of complementary or alternative medicine usage. He required hospitalization for the acute febrile illness, lost CHR. So initially again started on hydroxyurea. So after repeated counselings, so there was a problem that ponatinib is still not available in India. So somehow we are able to procure the ponatinib and started at 30 mg once daily from August 2023. The major toxicities were cytopenia. So there were a lot of financial issues, social issues, and infrequent follow-up. So the dose was reduced to 15 mg. So the last follow-up was in April 2025, and he's in CHR, but the BCR-ABL was 11%. So these are the points per discussion. So the patient used imatinib for quite a long period of time. After that, he lost the response. There was infrequent follow-up. So thereafter, he had a mutation Y253H. He was started on dasatinib 140, not tolerated the drug well. Later, the dose was changed to 100, no response. So dose hiked to 100, again 140 mg. But he had no BCR-ABL response at almost 8 to 10 months post usage of Dasatinib. So we repeated the TKD mutation analysis, and then the T315 had shown in the TKD mutation analysis, started on Ponatinib 30 mg. So in financial issues, he can't use that at a dose of 30 mg. So he's using it at a 15 mg once daily. So now the BCR-ABL was 11%. So the points for discussion and how we would have better managed this patient. So what should be our ideal targets and response, especially when we are using a second line tyrosine kinase inhibitor? Still, we should follow the criteria which we use for the frontline DKA. So the same stringent criteria of 3 months attainment and the 6-month attainment after the second usage. And how can we maintain the dose intensity in second line? So majority of at least 40 to 50% of the patients I had started second generation, second line TKs, either Nilotinib, Dasatinib, or Bosutinib. There was a problem in maintaining the dose intensity. So is the dose fixed, or can the patients respond at a lower dose point also? And what is the ideal dose? So for this patient, would you have started with 45 mg or 30 mg is good enough? And how will you adjust the doses of Ponatinib? So, or if the provided the finances are not a reason. So at this point of time for T315, still you start Ponatinib or with the availability of Asciminib, because in India still Ponatinib is not available and Asciminib is available. So would both are equally good options, or one is preferred over other at this point of time? And what is the role of allogeneic stem cell transplant, which is widely available in India now, and many are experienced in doing the transplants?
Um, Great. This is I think one thing that kind of sticks out, like these patients in this age range are tough, right? And that's not one of the questions you're asking, but I'm just highlighting that because I feel like the 20 to 30 year age range compliance can become much more of a challenge, and it seems like that is worldwide, not just a problem where I am. So to answer your first question, how would I have better managed this patient? I certainly wouldn't use the word better. I think that you did what happened here is probably exactly what should have happened. I do think that it's kind of interesting. This patient had a deep molecular response on Imatinib. They had an early molecular response. They had a deep molecular response on Imatinib that was maintained for what we think was at least 6 years, if I got those dates right. And then all of a sudden developed a new mutation, which is a little out of the ordinary. I mean, you would expect that someone who had achieved that early molecular response and then had this maintained deep response for quite some time would just kind of stay stable for many years to come. So it is interesting, and it does also make me, knowing that the patient was lost to follow-up and was using other things, it kind of makes me question their adherence to their Imatinib kind of in those later years before switching. But I mean, when they were losing response, you got the mutational analysis. It showed a mutation that would be, leading to resistance to Imatinib and Nilotinib. You put them on Dasatinib. Personally, I don't use 140 milligrams of Dasatinib because, just like your experience, I've yet to find a person who can actually tolerate that. And I don't know that that high of a dose is necessary. I'm sure in some people it is, but I think in most cases you can get the desired response. If Dasatinib is going to work, it will work at 100 milligrams. So that may be the only thing I would have done differently, right or wrong. I don't know, because in this case, it doesn't look like the 100 milligrams of Dasatinib was really any more or less effective. In the second line and later, I still tend to use kind of the same milestones and response criteria early on. I will kind of reset the clock and hope that if someone's lost hematologic response, or if their BCR-ABL is as high as 60%, my goal would be to have them below 10% after 3 months, and then below 1 or 0.1, within 6 months or a year. But the likelihood of that is lower, of course, but that's still my kind of ideal situation. But also recognizing that from one patient to the next, you kind of have to reset your expectations, because some people will just prove that they're just not going to meet those milestones. And so you have to start thinking of alternatives. I do think that side effects are problematic in trying to maintain kind of these standard doses of any of these TKIs, honestly. And I question whether, that maybe that patient was, I'm hypothesizing here, but perhaps they were not as compliant as we'd like to think with their imatinib because of side effects as well, but they weren't showing up for appointments, so it's hard to know that. And so I'm, even in the second line setting, I'm still pretty quick to dose reduce if someone's having side effects, especially when it's impacting compliance, because I of the thought that 50 milligrams of dasatinib taken every day is going to be a better option than 100 milligrams taken 3 times a week because someone's having side effects. So I think that is the way to kind of maintain an overall dose intensity, is to make sure they're taking whatever drug they're on daily. And if that requires dose reduction, I think that's very reasonable. With ponatinib and the dose of ponatinib, this is a good question. And, based on the OPTIC trial, I probably would say start at 45 and then lower the dose when they respond. But when it's a financial constraint, I still think 30 is very reasonable. But I would have started at 45. I don't know I don't think it would have made a difference in this patient because this patient's not responding to ponatinib either. So then switching to ponatinib 45 versus asciminib. I mean, if the patient's PCR after, I'm sorry, I don't remember the exact timeline that they've been on the ponatinib at this point, but it's still 11% after many months on ponatinib. I don't believe that increasing that dose up to 45 milligrams is going to really get you where you want to go. Is asciminib going to do it? I don't know. In the T315I population, my go-to is still ponatinib. Obviously, we have efficacy with asciminib, and in your case, if it's readily available, whereas ponatinib is not, then of course that's the direction you want to go. Again, in a young patient with some history of compliance issues, asking them to take 5 pills twice a day on an empty stomach that's a tall order. So I worry that compliance would be a bigger issue in that setting than taking a 45 milligram tablet once a day. But in this person's case, they're not really responding to ponatinib. So I think switching to asciminib would make sense. But at the end of the day, I think this patient's going to require a transplant. They're not responding to what the drug that has the best data, in my opinion, in the T315I setting. And this patient's, I mean, they responded so well in the beginning. There's, I think, more driving this than potentially just BCR-ABL. So I think this patient should certainly be evaluated for transplant. A donor search should probably be started. But in the meantime, maybe switching to asciminib to see if you can establish a response would be a very reasonable thing to do. And then if they respond, you can delay transplant. If they don't, then you've got transplant ready to go.
So coming to the
Sure.
previous case, so regarding the maintaining the dose intensity, so for the new case of CML, you told that dasatinib you started 100 mg and based on the toxicity, you cut down it to the 50 mg. So can we do it at a reverse manner? So can I start the patients on all 50 mg and check the 3-month response? And if they are not okay with the 3-month response, I step up the dose to 100 mg. How common is it for a patient to respond to 100 mg if they have not responded to 50 mg?
I can, off the top of my head, personally, can think of like 1 or 2 people where, they were down at 50, they weren't responding. I increased it back to 100 and they regained a response. I think, again, the bioavailability of dasatinib is kind of all over the place. And so it's really person dependent. I think obviously it's pH dependent. So if someone's taking anything to lower the acid in their stomach, that's going to have an impact. And with that, obviously diet would have an impact because that's going to impact pH. So all of these things are complicating factors. But I would, if someone was on 100 and then they had a response, you lowered the dose because of side effects and they lost it, I would certainly try going back up again. So with that, if you start at 50 and they're not responding, I don't think it's unreasonable to go up but I wouldn't necessarily wait 3 months to repeat it and see if they've responded, because if they're not responding, then we're just allowing them to continue to progress. So I'd probably check a little bit earlier.
Yeah, and I 100% agree with Dr. Kendra that there is a good, more than half of the patients who have very little toxicity to 100 milligrams of Dasatinib, 50% of patients. So you might as well give them the standard dose, the dose for which you have the maximum amount of data, and you only reduce if there is toxicity. It's actually a matter of philosophy, like so many TKIs, and particularly TKIs for solid tumors, they're quite toxic. And then again, you have a choice of starting small and going up on the dose scale, or starting at the recommended dose and going down if there is toxicity. But my personal take is that start at the recommended dose. If toxicity, then go down. Back to you, Stalin.
Yeah, thank you, sir. So I'm moving on to the second case. So this is a 26-year-old female, so who is a homemaker diagnosed with CML-CP in May 2010, so almost 15 years back. So the initial CBC showed a WBC count of 2.8 lakh, and the initial bone marrow was suggestive of CML-CP, and the BCR-ABL major transcript was detected, and so-called NDLTS was high risk. So started on Imatinib mg 400 mg once a day, attained CHR in 3 months. The BCR-ABL at 1 year was 0.1. And after almost 2 years, the BCR-ABL was 0.053. So she was continued on Imatinib 400 mg once a day, and the BCR-ABL in November 2013 was 0.001, so it attained a deep molecular response. But the patient, after 5 years of diagnosis, lost CHR. The BCR-ABL was 50.1%, and bone marrow was suggestive of a partial hematologic response. And the BCR-ABL kinase mutation testing was done, no mutation was detected. And this is way back 10 years back. So when the majority of the second generation TKIs are not available, or even though they are available, they are pretty costly. So majority of the patients who received the TKIs on the program, there was an option of dose hike to 600 and later 800 mg. And this patient was a dose hike to 600 mg of imatinib a day. So the patient, the November 2015, there was no CHR, 14.8% of BCR-ABL. So after repeated counselings, the patient was started on Nilotinib 400 mg twice daily, continued it for 16 months, no much response to the Nilotinib. So in May 2017, the BCR-ABL kinase testing mutation was done. So it was no mutation was detected, and the patient was changed to Dasatinib 140 mg once a day. So almost 8 months of Dasatinib, there was no response. The BCR-ABL was 36%. And again, kinase mutation testing was done, and this time it was F317L, which was detected. So as we know the F317L, so then it was thought that Nilotinib was a better choice than Dasatinib, and the treatment was changed to Nilotinib again and continued for 2 years with some partial response. And at the same time, the patient was counseled for allogeneic stem cell transplant. But she was lost to follow-up, visited multiple hospitals, tried Bosutinib in between for a few months with no much response. And later the BCR-ABL in January 2023 was 28%, and the TKD mutation at this point of time, it was suggestive of T315 mutation. She was counseled regarding the disease status and was started on 15 mg initially of Ponatinib. Later, the dose was hiked 30 mg once a day, but there was no response to Ponatinib and she didn't attain CHR. Later, so the compassionate program access was for Asciminib was available with us. So she was applied for that compassionate program of Asciminib, and she got the luckily the enrolled into the program, and she got Asciminib tablets and was started on the same since May 2023, almost 2 years back at a dose of 200 mgb. So she attained CHR in 5 months. So she had a good response to Asciminib. But she had increased triglycerides and started on statins and no other issues. She's being continued on Asciminib, but dosing was bit irregular due to the logistic issues, because every 6 months under compassionate program, the tablets to be shipped to her. Her present BCR-ABL was 4%. Using Asciminib, CBP and bone marrow were in remission. So the points for discussion are, so your opinion on management of this case. So Particularly, so our doubts were, so is there a chance of other second generation TKI working if one of them has failed? So for example, so we until 2 to 3 years back, we don't have availability of the ponatinib or asciminib. So if the patient has not responded to nilotinib, is there a point in switching over to dasatinib or bosutinib in such cases, especially if the kinase mutation domain testing was negative? And in this patient, so what is the chance of a T315 mutated patient who are not responding to ponatinib either 15 mg or 30 mg? We have not used 45 mg in this case. And given the availability of two, so this we have already discussed here, what will be the ideal choice as of today, because both work in T315 mutated CML.
Yeah, so again, interesting that this is a patient who had an excellent response for many years and then lost it. I mean, did she say anything about stopping her drug or cutting back on what
No,
how much
no,
she
no.
was in? No?
Majority of the times these patients don't stop the drug because they get them at the free of the cost under the compassionate access
Okay.
program through the GPAP.
Okay. It's interesting because it's just two of them that are again young, and I'm profiling there, but young patients and doing beautifully, and then all of a sudden they lose it, and that's very interesting to me. Um, but overall, I mean, the management I think was very appropriate. I mean, it's really hard in these patients when they lose response and then there's no mutation. There's not a whole lot guiding you on what TKI you should use next. So it kind of just needs to go, in my opinion, based on the side effect profile of the drug and the patient's comorbidities and um, those same sorts of decision-making factors that you would use even in frontline therapy. Obviously, you would just be, if you were already on a second gen, you wouldn't go back to imatinib. But since this patient started on imatinib, then I think any of the second generation TKIs would have made sense in this patient, given that she didn't have any mutations. As far as the chance of a second generation TKI working, if one of them has failed, um, my very short answer to that question is no, they typically don't. I mean, you can certainly see it, but if there is a mutation that's leading to resistance to dasatinib or nilotinib and you switch, then yes, I think in that setting you're much more likely to see a response. But in this case, where no mutations were found initially, I don't think there's great data to suggest that you're going to get much of a response with another second gen if one of them has already failed and it's not because of mutations. And even looking at like the Assemble trial, right? The Dasatinib versus asciminib in third line. I feel like that study was done in a setting where Dasatinib was kind of set up to fail. It's just not a setting where Dasatinib is typically going to work, and you see that with the results with 10% MMR after many years on that study. So it's a if you don't have another option, I think it makes perfect sense to try. But I also think that if you've got options like ponatinib and asciminib to use in the third line setting, that would be a better approach. And then obviously later, this woman developed a T315I mutation, and the response rates in these patients is often quite good with ponatinib, although after multiple lines of therapy, that those responses do decrease. And she seemed to have multiple, or she at that point had a couple of different mutations, and she'd been on it sounds like all three second generation TKIs. So she was getting to a point where I think there was more than just T315I as an issue for her. And then given the availability of asciminib and ponatinib, again, I would love to see a head-to-head study. And I think most of us would love to see that. And we're not going to see it, but it's really hard to know which drug is better with T315I and without. Because to me, it would have been great if that Assemble trial could have been ponatinib versus asciminib rather than bosutinib versus asciminib, because that is, at least for me, that's more in line with how I practice. And we still don't know which drug is better, ponatinib or asciminib. And we have some of these retrospective analyses that have tried to analyze that. But interestingly, when one is sponsored by Takeda, ponatinib is better, and when it's sponsored by Novartis, asciminib is better. So it's still hard to know. So I think you go by what you have available, and in your case, asciminib makes the most sense. But again, I've said this previously, I do worry about compliance in these patients where they need to take 5 pills twice a day on an empty stomach. That's hard. Even the most compliant patients will struggle with that, and so that's another reason. If all else is equal, I would choose ponatinib in the T315I setting, but in this case, it didn't work. So you had to go to asciminib, and then it sounds like this girl may also be heading towards a transplant.
Yeah, and would you agree, Dr. Kendra, that toxicity-wise, asciminib is much better vis-a-vis ponatinib? Like the vascular toxicities with ponatinib, even with lower dose, are significant and quite frightening.
Yes, 100% agree. And definitely when you look at tolerability, when you look at not just side effects that patients complain of, but the potential for the cardiovascular toxicity, asciminib, hands down the better drug. But and there are ways, I think, to try to mitigate some of those risks with ponatinib. They're not great, they're not perfect, they're not all proven, but certainly I try to get our cardiologists involved very early on in any patient I put on ponatinib because of those risks. And so asciminib is definitely the better option in that setting. I just don't know if it's more effective or not than ponatinib in most of these situations.
So Stalin, over to you. Carry on, please.
Yeah, I said these are the points for the discussion in this case.
Okay, so we open the case to the audience. There was one question about the dose of asciminib in the chat box. Like what is the dose in the patient who has the T315I mutation, which was, adequately addressed by Dr. Stalin. It is 200 milligrams twice a day. But if you don't have the mutation, then the dose is significantly lower. And that also translates into a multiplication factor for the cost. So again, that becomes a really big issue if you have the T315I mutation and you need to take 200 milligrams twice a day of the drug. It is really, truly obscenely expensive. So I think I'd like to ask Stalin that whenever you see a loss of response to either the first or the second generation TKI, what is your first concern? Like, what would you like to be sure of for a patient who's doing well for 6 years, 8 years, and you do a BCR-ABL testing, and then you find that there is loss of MMR? Then what are the steps which you should do? What do you advise our young residents who are listening to this program?
So the first step is to check and ensure the compliance. So the compliance should always be more than 90%. So ideally, so majority of the times in Indian setup, so what we do see in our routine practice is that there will be frequent message of use of pills. So the first and foremost thing is to ensure the compliance. The second most thing is to check. So the usage of alternative medicine and other medication is pretty common in India because once diagnosed with cancer, so there will be high usage of complementary and alternative medicine and also various other drugs for the illnesses. So we should thoroughly check what are all the things the patient is taking. So whether they can interact with the absorption or we can able to decrease the levels and the efficacy of the drug. So we need to thoroughly ensure that there are no such drugs the patient is taking. So if we fulfill these two primary criteria, then we go and check for the TKD mutation analysis so that if at all any mutation is there, we choose the second line TKI based upon their mutation. So ideally, majority of the times, if you're doing and the finances are not a problem, it should be through the next generation sequencing. So do a BCR-ABL kinase mutation and choose a second TKI based upon the mutation.
So I'd like to ask Dr. Kendra, like in the US, are all the kinase domain mutations are done under NGS, or are you still doing some patients in Sanger?
I have not seen Sanger used in a while.
Okay.
Where I am at Moffitt, it's all NGS, and most of the outside reports that I see are also NGS.
And what happens when your NGS throws up multiple mutations? Then, I mean, that is very, very frequent when you do the NGS. It's too sensitive for its own good. Then how do you decide which is the driver mutation? Of course, if you have the T315I, you know that trumps everything else. But if you have two or three of the other ones, then which becomes the driver mutation? And how do you know, one mutation is sensitive to, say, for example, Dasatinib, one mutation is sensitive to Nilotinib. Then which one do you
Sure.
decide?
So I don't know that there's a great way to do that, similar to like AML when you've got FLT3 and IDH. How do you know which one to go after? It's really hard to know that. And so I'll look at the variant allele frequency and you know, if there's one that's 7% and one that's 40%, then I guess I kind of assume that it's the one with the higher VAF that is driving the disease more. But it's also hard to know if these are like in the same clone or there are multiple clones. So in those settings, that's usually when I will go to Ponatinib. Although, you know, Ponatinib in the setting of compound mutations with multiple mutations in the same clone, the efficacy is still not great, but I think it's the best option that we have. So that, you know, if I see more than one, that's usually my go-to.
Right. So there's another question in the chat box. Then when you have resource constraints, then would you like to ask for an NGS or a Sanger? And I think that's a no-brainer. If there are resource constraints, then Sanger is significantly less expensive. But if there are no research constraints, then the sensitivity of the NGS is significantly better than the Sanger. Is that right, Kendra?
Yeah, I would totally agree with that. Absolutely.
Okay, and there is some concern that Asciminib might be producing a lot more mutations than the other TKIs, especially when used in the first line setting. So what's your opinion on that, Kendra?
I think we need to, I guess there's, you know, the possibility of, this is all hypothetical here, but like, you know, if someone picks up a mutation, can we add another drug that maybe could work in the setting of that mutation and give two drugs simultaneously? Is it just, I think it's early, and I think we need more frontline data, longer frontline data to really know how concerning this could be. And then what's the best approach to managing it when we're seeing those mutations. And that, I guess, is that somebody asked earlier, do second gen TKIs work in the second line setting after asciminib failure? I am not familiar with data to support that or, you know, show that that doesn't work. I'm not familiar with a whole lot of data in that setting, but that's kind of what we're left with. If you know, if you develop a mutation that leads to resistance to asciminib, you're left with ponatinib or a second gen drug. So that's the hard part, I think, with going to your best drug up front, but also you're going to get the best response and hopefully get deeper responses and maintain those responses even longer if you are using the most potent drug up front.
So one more question to you, Dr. Kendra. Like you have a patient with the 315I mutation. So would you use asciminib or ponatinib as a bridge to transplant, or would you continue them till there is deep molecular response and think of a transplant only if the patient loses the deep molecular response? So is that the third line or the fourth line treatment? with transplant as the next line treatment, or is it a bridge to transplant, these two most effective agents in the 315I setting?
Typically what I do is send them for a transplant evaluation, start a donor search, but also with the plan that if they respond, I won't send them to transplant. If they get a nice response to ponatinib or asciminib, I'll continue treating them and then just kind of keep transplant in the background. But the timing of that typically works out relatively well by the time we know if they've got a suitable donor and they've gone through the whole transplant evaluation to make sure they're a good candidate. We also have had enough time on ponatinib or asciminib to confirm if they're actually going to respond to it. And I know there's some people who would, especially before asciminib came along, who would say, why would you want to expose someone to the potential risk of ponatinib toxicity for an extended period of time if you can send them for transplant? So I think there's people who would definitely disagree with me on that, but transplant is certainly not free of toxicity either. So I think if they're tolerating ponatinib or asciminib well and their response is good, I would keep them going on that before transplant.
Yeah, so transplant becomes maybe the fourth line option or the fifth line option, right?
Yeah.
Okay,
But I'm not
so
going to
we
wait until they've failed to then start working up the transplant. I'm going to do those two things simultaneously.
Okay, wonderful. So I think we are almost at the end of our time. If there are any other questions from the audience, then we would like to take those. Otherwise, we'll see if we can wind up this regional discussion now. With many thanks to our presenters of the evening, our two regional presenters, Dr. Mipsang and Dr. Stalin, and our two international experts, Dr. Gian Antonio and Dr. Kendra. So many thanks to these experts who made such incredible presentations, some really good cases, and some unique points for discussion which concern all of us on a daily basis when we manage patients of CML. So before we close, we would like to inform you and convey to you that the next Southeast Asia Regional Discussion Group webinar is going to happen on Wednesday, the 2nd of July. And we have, again, two regional experts and two international experts. The regional experts for the 2nd July regional discussion group is going to be Professor Raghunath Rao, like he's a teacher to so many oncologists and hematologists in India. And the international expert is going to be Professor Mari Copeland from Germany. And the other regional group discussant is going to be Professor Ali Khan from Pakistan. And the international expert is going to be Dr. Jeff Lipton from McMaster, Canada. And we are going to discuss difficult CML cases from across the Southeast Asia region in this particular program. So with that, we'd like to close this webinar, and many thanks for your presence and your attendance. Many thanks to our presenters of the evening. We've had some really good discussions, and I hope you are enriched with knowledge and better equipped to deal with your CML patients when you see them either this week or next week. And many thanks to our back office people, particularly Dr. Arlene and Nikolai and the ICMLF for getting us together and for this really good meeting. We hope to see you in more and more numbers in the next program. So thank you very much, Kendra. Thank you very much, Dr. Stalin and Dr. Lama from Nepal. And we hope to meet you soon virtually and hope to meet you soon in person sometimes into the future. Thank you very much.